so much for having me. It's absolutely an honor to be here. And I see some really wonderful people I've spent a lot of time with in the past. Perfect. And I have been honored truly to benefit from Dr. Holsinger's mentorship over the years. I think there's a lot of young people in the room. It's really important to look for folks during your career that not only mentor you but sponsor you and advocate for you. And Karthik was one of those as well. And so it's really, really humbling and exciting to be here today. And I get to talk to you about one of my absolute favorite topics, and probably one of yours as surgeons, and that's anatomy. And I'm going to give you sort of a little bit of background as to why I spent a lot of time thinking about this, and still spend a lot of time thinking about this. And anatomy is one of those subjects that you never master. It seems like you might master it, but you just never master it. Every time I'm doing one of these projects with my team, I learn something new. One of my medical students finds some literature on a structure that I've looked at many times, and it's like a brand new thing. It's so fun. I really, really enjoy it. So I'm hopefully going to share a little bit with you guys today about why I love it and why I think pursuing, having an ongoing pursuit of anatomy knowledge is really important. Let's see if I can. Here we go. So I do have some disclosures, and they are here. I don't think any of them are related to this talk. So overall objectives for this talk, I want you to understand what extended reality is. There's some different types of extended reality, including augmented reality, virtual reality, and mixed reality. And these are new terms that are coming on board, and it's nice for all of us to be aware of them. I want to make sure that we review some of the techniques that we can use to apply these to different settings, whether it's bringing it into the operating room and using it during surgery, bringing it to our patient's bedside and helping them understand their disease a little bit better, or educating myself or my colleagues, our medical student doctors, or our residents. And then we're going to talk about why I think that this is really important in head and neck. I will say when I decided on ENT as a medical student, one of the clinchers for me was that I got to keep the most number of Netter's flashcards. So if you looked at Netter, the box, I got to keep the most if I went into ENT. And so that was like, all right, I'm going to do this. And then lastly, I was able to bring a couple VR headsets, and we've loaded on some of our rooms. Like you get to go to a museum and play with the anatomy. And so feel free at the end to stick around, and we'll be able to do that. So let's start with some of these advanced educational tools and immersive technology. What does that mean, and how do we use it? Extended reality, or XR, is sort of this umbrella term that's used to describe immersive technologies that can merge both the physical and the virtual world. And so there's several different types of these. First will be our augmented reality, all right? So that would be, we have some virtual information or an object, and we are bringing that into our world that we're seeing. So I would be looking out at all of you, or I'd be standing in the hallway outside our anatomic modeling lab, and I can use a device. And that may be one day a James Bond style set of glasses that can show me an image layered onto reality, or maybe it's my phone. I hold it up like you can do here, and all of a sudden there's a brain weirdly floating out in the hallway, or a heart. And so you can play with that in your space, and there's lots of different reasons we might want to do that. Next, we have virtual reality. I think we're all a little bit more familiar with this. So this is a fully digital world where you are in the room, you're in the operating room, you're personally talking to the patient, you're in an immersive environment. Most of these are video games, things like that we're playing. But Dr. Morris, who some of these photos are from, has used it to create, so he's a radiologist, a neuroradiologist, and there's a lot of radiation safety things that you have to do. But radiation safety is really confusing. It's something you have to imagine. No one can see the radiation impacting you when you're standing in a room. And so creating this virtual reality room where you can see the scanner, you can see where the radiation, hotspots are, things like that, how to keep yourself safe is a really new way to teach and train and onboard people to be safe. And the last one we'll talk about is mixed reality. So mixed reality is when you combine several of these. And so you have the real world, and it's anchored with digital elements that interact with the user. And so that can be the environment or both. Sorry, the user, the environment, or both. So it's really kind of exciting. This is Michelle Clark. She's one of our orthopedic spine surgeons. She's interacting with the natural environment, the physical world, but she's also having this augmented reality layered into it. So that brings us to our medical XR. So again, XR is that extended reality. And you can see there's lots of different things here. So we have VR, we have 360 video. Maybe you're able to like really like be in this space and see around. We've got our augmented reality with our Quimby glasses. We've got apps. I hope you all have your phones with you. I'm sure you do because you'd be lost without them. Because I have some QR codes so you can pull up some of this and play with it on your phone. We have photogrammetry. Has anyone heard of photogrammetry? All right. So you take out a tumor and it like weirdly looks beautiful. You know, like nobody else would think that. We're weird for thinking that, but it looks really unique. And when you see it in the textbook, it's like perfectly yellow and it doesn't look like that. But in reality, this tumor, you know, the way it looks, the way it feels, it matters. It like adds into the way you understand how to take it out. Now we can surface scan that and get the exact replica of what it looks like on our in our XR. And so you'll see that with some meningiomas and some skull-based cases that we have in one of the rooms here. But using photogrammetry might be a really nice way to educate people who've never taken out that tumor before and don't know what color to look for. You know, when you're operating the parotid, for example, you know, after you've done a lot of these, you start seeing the color, you see the shade, and you're like, oh, I know where the tumor is. And there's this sort of knowledge you get just from the way it looks and feels. And so maybe we can start adding that into our education. So how do we go about using this and bringing this to all of us in our daily life and answering problems that come up for us that we'd like to be able to use it for? So we talk about innovation is important for co-creation. So innovation isn't just driven by technology and devices. It doesn't matter. It doesn't matter that I have access to this tool. What matters is that I had a problem. I wanted to better understand the anatomy and be able to teach that anatomy better to my residents. And so by having a problem and then having people I could talk to about the problem and then having access to resources to address the problem, I was able to come up with a solution. And so it's really that junction of innovation and need. So we need to make the tools available and then play with them, encourage creativity, encourage questions and problem solving. And again, I think nothing comes without a good team and teammate. This guy, Jay Morris, is that for me. And he and his team have built this amazing 3D lab where you just pop in with a problem. You know, one of my colleagues is a pediatric otolaryngologist. He came in because he had a patient who, you know, he was really worried about how he was going to do that tracheal resection. And they did this whole modeling and printed him out a subglottic stenosis trachea, and he was able to slide it around and cut it out and put it together in different ways. And so it's having that team. So we have surgeon, neuroradiologist, biomedical engineer, and you have to have institutional support. I mean, it's a lot of space that we need. And then you have to have a problem. He has an open door policy. Clinicians just pop in and give him problems, from gynecology problems, orthopedic problems to head and neck. Unfortunately, he's a neuroradiologist, so he likes head and neck anatomy, which is great. So what problems do we aim to solve with all of this? I mean, I think each of us could come up with a bunch that we are aiming to solve, but from sort of a basic level, the first is looking at intraoperative challenges. So our surgical navigation is pretty good, but it could be better. And it could be accessible to multiple people in the room. It could be accessible in a way to surgeons that it isn't right now. I'm a reconstructive surgeon. I like to make 3D models of the tumor and the area I'm going to cut out. I make a 3D cutting guide that I put on the fibula. And no matter how much time I take trying to make that cutting guide perfect, when I put it on the fibula, it never fits quite right. You know, like it just is kind of off, and I just accept the fact that my screw doesn't see all the way down at the bone. And it may be because I'm like off by a centimeter here or there on the bone. I'm just not putting it on right in that complex 3D anatomy. And what if I had, you know, this augmented reality where I could have points on the bone that are registered, and then all of a sudden it would layer on and tell me exactly where on that bone to cut? I think we could do better. So we have things like projecting that segmented data over the patient in the field, or maybe replacing the screen. Maybe we don't all have to, you know, there's these new technologies for micro, but you really have to be looking at the screen, and somebody's head's always going to be in the way, or, you know, it's nice to be able to look wherever you want and be able to see the information that you need. And so this is my colleague Dan Price. We're tending to do some augmented reality surgery. He's clearly not struck in, but you could see it'd be pretty cool. You could scroll through images, and there's a lot we can do with that. Next is in education. And so this makes a lot of sense, right? We can bring our anatomy and our surgical learning to our learners where they're at. We can teach people surgery. We can teach people interventions. It's never as good as the real thing, of course. You never have that pressure, but it's a way to start. We can have a global reach, so you can teach people anywhere in the world as long as they have access to the technology and can have some oversight. it's really cross-disciplinary. So the anatomy we put together is not only good for all of us, but it's good for our radiation oncologists, it's good for our radiologists, it's good for our medical oncologists, it's good for our speech therapists. Like, it's good for everybody who's trying to interface with this anatomy. And we can inspire the next generation. So this was us. We have a really nice relationship with this company, YU. It provides longitudinal mentoring for students. And these are a bunch of students that I don't know that they're interested in medicine, but by showing them the anatomy and bringing it to life in a different way, maybe we can inspire people to go into medicine, which is cool. This is an area we don't think or talk about a lot. A lot of these models are for us. They're for us to make better surgical decisions. They're for us to understand the anatomy. But it's really helpful for patients. I've had a lot of patients ask me for their models afterwards. So they take them home, and it's sort of like a representation of what they fought through. And it's a way for them to show their family, this was in my body, and I had to have it cut out, and that's why this is happening to me. So it's really a potentially nice way to do this. I mean, Jane Morris imagines a world where we're all sitting in our exam rooms, and you can pull up the scan and put it in 3D, and you can turn it around, and the patient can really understand what we're talking about. And so I think that could be pretty neat. We can do virtual reality fly-throughs of a pathology, and potentially even through our patient portals provide disease-specific XR or extended reality to our patients. So we talked about some of the problems that we aim to solve. Let's talk about where we aim to solve these problems. I don't know if you guys were in cadaver labs in medical school anymore, but I definitely was in this room, and it's busy, it's crowded, it's amazing. It makes you feel like you're doing something really meaningful. It's where I fell in love with surgery, but we have to be co-located. You have to have a lot of resources right there. You need somebody that's going to be teaching you right there because it's really challenging when we think about the way that the Mayo brothers first taught us to learn surgery, where everybody is in this, operative theater looking down at the patient and trying to understand what's happening between these two hands, And I'm certain that all of us have been this poor person in the room over here who can't see anything. And not all of us are so lucky to be as tall as this guy and be able to learn what's going on. And so by creating these novel educational opportunities, we might be able to get away from that need to be co-located with the specimens, with the teaching opportunity. And this has like a lot of implications. I think there is nothing that replaces being in the operating room with somebody who's going to mentor you and guide you through that case, or being in the cadaver lab and having somebody walk you through that. I mean, that is so impactful, but it's just not reality all the time. And maybe you get to have that experience. And like me, you go to the cadaver lab at least once a quarter for your residency. But I only got to do that for 4 hours that day. And I can't get back to that anatomy when I want to refresh myself. This is something that you can have with you in your pocket. We can create amazing 3D models that you can take home with you and you can pick up and you can look at and you can, bring yourself back to and remind yourself. And maybe we can make things that, we can break apart and you can put magnets in here, or we can have it so it's a puzzle and you have to physically put it together, because we all learn better when you have to do something with the anatomy, when you draw it or when it's yours. Or maybe we take that anatomy and then we put it onto an AR platform. So this is cloud-based. It can be available on any device. It's HIPAA compliant. And then all of a sudden, you can take your device and have that anatomy. And you can play with it, you can look at it, and you can refresh yourself. And before that case that, you didn't know you were covering Dr. Holsinger and he's got some weird case you need to do, well, you can pull up your anatomy and refresh yourself. And so that would be really nice. And then again, no matter where you are in the hospital, wherever you are in the city, the state, the country, the world, you would have access to that anatomy. So here's your first opportunity to have it in your hands. Hopefully this works. But you can take a picture of that and open it on your device. There'll be a couple of these. I should have had like little papers you could get them.
I was wondering, do you need water as well?
What?
You need water? No.
Okay.
Okay.
Really like dry out the larynx.
Yeah.
All right, looks like you guys have it. So I've hopefully convinced you this is really cool and that we should all be thinking about it. And so let's talk about how it's related to head and neck and how I got started on this. So I was in a conference, sitting in the audience, minding my own business. I was a fellow, and Dr. Kinney, who is one of the transoral surgeons down in Mayo, Arizona, he says, he called me out in front of this crowd and said, Dr. Van Abel, thank you. What do you encounter first when you're doing a transoral supraglottic laryngectomy? Is it the superior laryngeal artery, vein, or the nerve? And I was like, oh my God, how does he know my name? And why is he calling me out in this crowd? And, his point was that we have to know our anatomy, not only from the outside in, but the inside out. Fortunately, Dr. Moore and Dr. Henney are like two sides of the same coin. He'd already asked me that question many times, so I was able to get it. But if you look at this is how we're traditionally taught anatomy, right? So we've got this beautiful drawing. It's from the outside in, meaning we've made an incision in the neck and we're going in towards the middle. And we can see that it's the vein and the artery and the nerve. But how about from inside out? That's important. We have to know that it's going to be the nerve and the vein and the artery. The nerve, the artery, and the vein. I have that hooked there. And that's relevant because when you're clipping a structure that looks like the artery, if you don't know that the nerve comes first, you might not have arrested the vasculature and be putting that patient at risk for a postoperative hemorrhage. And so that's really important to understand. And hopefully by the end of this, you will have it in your mind so that you'll be able to answer that question when hopefully nobody calls you out in a crowd. So Dr. Henney's point and Dr. Moore's point is that we have to know our anatomy from the inside out. You have to know it upside down, you have to know it backwards, you have to know it from the outside in and the inside out. It's all important because the pathology that we take out is going to destroy what you know based on the textbooks. And so you have to be able to do right by your patients. And this is relevant whether you're a head and neck cancer surgeon or not. It's relevant when you're doing tonsillectomy, when you're doing your adenoidectomy. I mean, anything you can think of as surgeons, it's important. Knowing our anatomy isn't just cool. It doesn't just make you a better surgeon. It helps us take better care of our patients. So we have several goals when we go into an operation. The first is that we want to treat the disease, whatever that disease is. We want to avoid injury if we can. Sometimes things have to be sacrificed, and that's how it is, but we should know the name of something that we're cutting. It shouldn't just be, I tell my residents, it's not a block of cheese. You don't just get to cut down until you hit the cutting board. We should know the things that we're cutting through. And we'd like to conserve function because we'd like these patients to go on and have an excellent quality of life. When we think of oropharynx cancer, so I'm very oropharynx cancer centric, although I like all anatomy. I'm not, I'm open to all anatomy. But when we look at the oropharynx cancer, which is where I started from with this project, there's a lot of reasons why that knowing our anatomy really well from the inside out is so important. Not only is our staging criteria based on being able to read a scan and really understand where does this tumor go, how am I going to stage it, but whether or not you can take someone to surgery also is related to their anatomy. So I need to understand when I'm looking at a scan, is this an exophytic or an endophytic tumor? When I feel it, can I move it? Is it stuck to the pterygoid fascia? How close is it to the carotid? Is there a retropharyngeal node back there? Where do I look for one of those? And on to try and understand. Maybe it's a base of tongue tumor that's really coming close to the hyoid and the seminubular gland. And then I need to know to be thinking about my hypoglossal nerves and things like that. So you really have to understand your anatomy. And lastly, we just don't have a lot of space in there. So this is a great paper by Dr. Henney and colleagues, and I've used this slide for other reasons, talking about extensive margins in oropharynx or transoral surgery, and that's not the point of this conversation. But if you look right here in the middle, if you look right down here, let's see, in the middle, you can see that the mean minimal thickness of the lateral pharyngeal wall musculature was just 2.4 millimeters. And if you know your anatomy, right behind that, well, we're going to get into our buccopharyngeal fascia, our parapharyngeal fat pad, and then the carotid is right back there. So when I give my full anatomy talk, we go through where's Big Red, how do you find that and feel comfortable with that and know your anatomy. But we don't have a lot of space. And so it makes it even more important that you can name what you're cutting through and that you can identify these structures on imaging. We also want to prevent injury. And so if you know your anatomy, you can stop yourself from getting into the thing that you shouldn't. You can be aware of the variations that may come up with your surgery, and we might be able to take less mucosa and muscle and leave our patients with a little bit more to work with when they're swallowing afterwards. It's not just the radiation oncologists that need to be practicing pharyngeal arch sparing or access sparing radiation, but we should be thinking about that in terms of surgery too. If we don't think we need a really wide margin, then you better make sure that the margin you're taking is necessary. We can try and avoid vascular injury, nerve injury. Think about our fistulas. When you expose bone, pressure hurts and it takes a long time to heal. But if you don't know where it is, you might accidentally do that. And I've certainly done that. And then lastly, we talk about function. So all of these things, one of the reasons that probably all of you wrote in your personal statements to residency is you love how head and neck intersects with hearing and eating a meal with family, and all of those things that every medical student writes in the personal statement, at least their first draft. And it is a real thing. I mean, our anatomy makes such a big deal. It's such a big deal for our patients and how they interact with the world. And so we have to be thinking about that too. One of my favorite quotable historic medical figures is William Osler, and I really think that this is so true. The eyes cannot see what the mind does not know. So if you don't know to look for it, you won't see it. And a little known quote is he also said, know your anatomy from the inside out. You may not ever be able to find that quote, but I'll tell you it's true. All right, so let's talk about how we took this new technology, understand what the problems are, where we wanted to solve it, and apply, understood where we want to apply it to neck anatomy, sort of bring these things together. So I was really trying to bridge my love for anatomy, the problems I was having, understanding it, with this immersive technology as it came out. So we have some things that we're all really familiar with. We have our 2D monoscopic images. This is, you open a textbook, there it is. You look at the figure I showed you of the larynx, that's your 2D monoscopic image. And that also is what you see when you look at a picture of a cadaver in a cadaver atlas. Then we have 3D images where you put on your glasses, and if you're like me, you're like, I can't make my eyes make sense of this, like is my head too tilted? But they're nice and they do add to our learning. And then we kind of layer that into video, and then we have our augmented reality, our extended reality, etc. So how do we bring this together? When I first started talking and giving talks on oropharynx anatomy, I have this awesome set of slides where basically I add things all together. And I like to be simple. When I think about the oropharynx, I like to break it up into subsets. So I've got my tonsil block, my basic tongue block, there's 2 of those, my glossotonsillar sulcus. I like to know what our boundaries and what I need to work with. But this doesn't really do justice to the complexity of this. So then we could say, is this any better? Well, it's really nice. It's a really nice picture. There were surgeons involved with putting this together, and so there's a lot more anatomy that we really care about. But I have so many questions looking at this. Like, is the facial artery going over the alveolus? I don't know. What happens to 9 down there? Is it really that big? Where do I cut that? I'm not usually cutting that when I come across the tonsilus. Normally the glossotonsillar sulcus or the inferior tonsil. Like, what happens in the back there where things get really fuzzy? Like, it's hard to see around there when I'm doing surgery, and that's where I start worrying about bleeding and things even more. And so this adds a lot, but I don't think it's quite enough. We went to the cadaver lab, and we've done a lot of nice dissections, and I think that there's a ton to be learned from doing those dissections and also from looking at them. And we have all of these nice pictures, and we get a little bit more of a sense that it's not so perfect as in a textbook. We've got a lot of fat, and things maybe not be exactly where the books told you they were going to be, and we can have labels, and you can learn from that. We try and put them into surgically relevant positions, but I'd say that you still, all you can do is look at this and try and understand the relationships and memorize it. So it's really important, but still not quite good enough. So how do we transfer that 2D knowledge into a 3D space, both 3D just digitally and 3D virtually? So I was fortunate to work with these amazing ladies. So we've got Dr. Tashi, so you can remember her as Slashy Tashi because she's a surgeon, or Flashy Tashi, just depending on what you're going for. And then Linda Yen is one of our new head and neck surgeons, so I'm fortunate to work with both of them. And Cheyenne is now one of our chief residents. And we went to the cadaver lab and did a lot of weird things, trying to take 3D pictures. And that's my daughter, and she had a new camera and thought it was pretty fun too. But with 3D, when you're trying to create a 3D image, you have to take 2 images of the exact same field of view every single time from each eye, and then add that together. And then we were able to take all of that 2D cadaveric data and put it online, so it's all on headandnear.com now, which you can go look at. And so you can see the different layers. You can see the 2D, you can see with labels, without labels, and then now you can see the 3D. It was really challenging actually trying to figure out, Cheyenne is an artist, and she did a lot with Adobe Photoshop. And so taking the pictures was challenging, but then also making it into something that could be 3D with all the cyan and the different colors that you had in there was actually kind of tricky. But I think it offers a really nice add. It adds to your knowledge. And so headandnear.com's got a bunch of these images, and if you haven't played with them, I think they're really nice. And again, they're on your phone. You can pull them up anywhere. But we wanted to go a step further, or just add to it. And so we put together this virtual anatomy team, and I think I've been working with this team now since I started on staff, probably. So there's Jay, he's standing in front of all of his amazing printers. And then down at the bottom we have Caitlin, she's a medical illustrator, so her entire job is to make beautiful pictures of anatomy. Like, what a cool job. And then Anna was a PhD senior engineer for virtual reality, so her job was to take all of the pretty pictures that we had and put them into a VR space. And then I was fortunate to work with George, who's an amazing medical student who was applying to residency this year, so take a look at him if you haven't. And then Dante, who's going into head and neck fellowship as well. But for some reason, he wants to be on the East Coast. All right, so where do we start from? You have to start from somewhere. So all of these things sound really cool, but like until you actually know what are all the palate muscles and what are all the tongue muscles and things like that, it's just something that we're thinking about. And one of the things that really bothered me is that most atlases I would look at would say soft palate musculature. You know, like it's not enough. If I'm going to name it and cut through it when I cut through it, it's just not enough. So we started with a young, healthy woman who had a CT angiogram. You know, I wish that we had some sex variety in there and maybe some BMI variety, but it's hard to find someone who has a really nice scan that doesn't have pathology. So that's where we started from. And you can see here we're starting to segment things and it looks really messy. You know, you're like, okay. We spent a lot of time, I spent time with the engineers, we went through all these muscles and I did a lot of literature review and we started to make them, come to life as we layered in what we were learning. We went from all of our 3 different axes and tried to make sure that we had things right, but it doesn't look very good, And then as we start to bring it through and start to bring it over to different platforms and have a medical illustrator start to work with it, you can see that it starts to get a little bit better, a little bit more refined, a little smoother. We had to take all of our segmented muscles, so this looks a lot better than it looked on the scan, but it's still not great. And then we optimized them in this CAD software called Freematic. And you can see that it adds a ton of these tiny little triangles, and the smaller the triangles are, the smoother your surface will be. So here's our palatal-glossus muscle. We're starting to make it a little bit smoother, a little bit finer as we refine it. And as we work through this process, we really went from these sort of lumpy, unrealistic objects to something that was a little bit more realistic, a little bit more educational, and offered a little bit, it was honestly just nicer to look at too. One thing you can see here, so, we always see these pictures where everything's nicely color-coded, and you're like, yeah, if I could look into the mouth and see everything color-coded, I'd be an awesome surgeon. So we also have to make sure that we're covering everything in mucosa and we're showing things the way that it actually looks. Here's another way to look at things. When we look at the oral tongue, the floor of mouth, I'm really good at telling you where the genea glossus is, or maybe where the hyoglossus versus the myohyoid, something like that. I can tell you where the arteries are and the nerves, and that's really important when we're talking about transoral surgery and things. But I couldn't really tell you where all the intrinsic muscles were or how they started and stopped. And so doing this project and really trying to understand that and creating a picture that helps you understand it was very educational for me. So now we can see that we have things layered out. We can really see where each of the muscles come in. We can cut things away. And we went from something like this, which is helpful, but then we added to it and we made it so that you can really see the things that you will be cutting across. You can see those septal planes. You can see the different musculature, which is pretty cool. There's different ways that we can look at this. And I think sharing this with you guys feels like showing something that's too soon. It's not quite ready. Because what we want to do is we want to be able to, click on this and you get some information. Click on that, you can see the images from the scans. Click on this, you can watch an operation where we're working with that. And so this starts to get there where we can kind of layer through and look at the different structures and look at it in different planes and take things away and try and understand what's under there and start to scratch that itch of really trying to understand, like we do in the cadaver lab, what's just beyond. What if I go just a little bit further? But this time you can put it back and you can do it again. You can put it back and you can do it again. So here is the first attempt at showing it from a transoral surgeon's view, looking at an oropharyngectomy. And so if we take that out and we have our nice tonsillectomy and we've removed our superior constrictor, what are we looking at down there? Where is that septum of musculature that's supposed to keep us safe from the carotid artery? Where are we looking at the stylohyoid ligament? What's the difference between that and our glossopharyngeal nerve? Well, we can't see it because we've got the tongue in the way, so maybe we can make that transparent and kind of see through. Maybe we can just take the tongue out of the way and really try to start understanding where some of these structures live. Maybe we can adjust our view. In the future, we can put this patient on a virtual operating room table. We can put in that annoying FK. We can push things out of the way and squish them so that you can see just as well as you can in the operating room. And hopefully we can start looking at this a little bit further. We were fortunate to partner with this guy, David Goldenberg. He's the editor for Operative Techniques in Otolaryngology, and he was really excited by some of the stuff we were doing. And so in December 2022, we were able to publish our first batch of papers on this. And it was exciting, it felt good. We have both cadaveric day sections that talk you through how to do step-by-step procedures, everything from a trach to more complex surgeries, and we also had our virtual 3D anatomy as well. And then they liked it, so we were able to publish again this last year, just in December. And the thing that we were able to add, which I was super excited about, let's see, so not only could we add some of the anatomy, but we were also able to add QR codes. So if you go to these papers, a lot of them have a QR code, so you can pull up our model and actually play with it on your phone, and you can have it, all right? Operative Techniques, probably have to get it, probably Stanford hopefully has a license to it. Because otherwise it's hard to come by because it's not PubMed, but it's a nice journal for surgical anatomy. And it was really cool because, like I said, it started with oropharynx anatomy, but I like all anatomy, and we were able to partner with my laryngology colleague, Dr. Bayan, and she really helped add to it. And you can see here's where we start, and this is what you often see in the literature is, some 3D image like this, and you're like, well, that's not all that helpful. But throughout the process, we got to something like this, and gosh, the larynx is so beautiful. When we start looking at the amazing cartilages, and you get quizzed on what are the barriers to spread for this tumor or that tumor, and where are the ligaments, and where's that quadrangular ligament, and it seems so abstract. Well, maybe this makes it a little less abstract because it can make it a little bit more real. And I really love this model, so definitely take a look at it. But hey, all of a sudden, when Dr. Henney asked me that question, and he pops into your life, you can look at this and you can really understand the relationship surgically from the inside out. So here, if I'm making my cuts through this way, trying to get around my epiglottis if I needed to or something like that, you can see here it's going to be my internal branch of the superior laryngeal nerve, and maybe I have a couple other branches. You can also see that sometimes it doesn't work perfectly. You come across the nerve because it's not a perfect straight course that is often drawn. And so we can start saying, I need to see this view. This is what's really important to teach this course, or answer this question or this problem. And because you can turn it around and move it and change it, it can be whatever you want, you need as a surgeon, which is really cool. All right, I don't know why I picked this little picture, but isn't it kind of cool? A little virtual reality satellite. So this is what you guys are going to get to see. So if we take everything we've just talked about, because there's value to those 2D monoscopic images, there's value to surgical video. There's value to having an object you can take apart and put back together. There's value to 3D surgical videos that you guys are making. And so can we put that all into a space that's really powerful and impactful? Well, yeah, we can. So here's our one of our museum rooms. And here you'll see I have a carotid, I don't know what are they doing. This is a peripharyngeal tumor surgery that I did. And we labeled all the anatomy, and that's nice, but maybe it doesn't make total sense. And so now we take this, so we can take this skull, and this is one of the ones we uploaded today. We put it in a surgical position. Here you can see the texture map, the muscle, so it doesn't look like this cartoonish pink. And then you can go to the case, and you can say, oh, okay, that's where that is. That's what it looks like live. You can pause it. Then you can go back over to the model. Oops, sorry, guys. You can go back over to the model and keep going back and forth. Here's a skull-based course. It's the other room we have loaded on here. You can see this tumor was scanned with photogrammetry, and so it looks like it did when it came out of the patient. We can pick up that skull, we can move it towards us, we can move it around. It's got that, I'm not a skull-based surgeon, I don't know what approach that was, bilateral or something. We can take the vasculature off, we can see the relationships to the blood vessels, to the bone, etc. We can click a scan, and it can pop up, and so you'll be able to do that here. We can scroll through the angiogram, we can maybe click a different sequence or series that we want to look at, and it's that patient's tumor, because that's where we got the data from, which is pretty cool. You can see as you walk around this room, let's see here, you can see other tumors in there, and there's lots of displays, which is very neat. So where do we go from here? This all sounds really cool, but I can tell you it was a lot of work. Being able to put these things together, it seems like, oh, just scan the patient and, segment things. It sounds very easy. It takes so long. So what we're hoping to do is be able to complete this anatomic segmentation and then really try and start texture mapping, adding in layers that are relevant to each of us, fully integrated into an app in virtual reality, and then create some digital twins. So we're going to create that operating room where you bring the patient in and you actually like walk into the operating room and you have to like expose the oropharynx and put in a blade and see the tumor, and then you can pause there and see it in lots of different ways. And then try and make it available to everybody. Be able to click. So what I didn't mention is for all of those publications, we did really a lot of literature review. And if you look in the cadaveric literature, there's all these variations. It's not just one of something. But we would pick the most common variation and use that for our model. But it'd be really nice if we said, let's take the second or third most common variation, and you can click on that, and then boom, there it is, and you can see it and see how it relates. We can put some different tumors in there. We can do procedures or let you walk through a procedure and actually see the anatomy you should be seeing. And then we can layer in things like our pathology, because we're still tested on pathology, so maybe you can pull it up and look at it in real time. And digital path's going to make that really easy. Then we can bring it with all of our different anatomy to all of our different learners, be it the most senior surgeon to the most junior, participants. So those are my two kids there. This is a course that we put on, and we have our 3D anatomy, we've got our models, you can scope these models, you can really engage with them in different ways. So that is what I have for you guys. Leaves us with about 20 minutes to answer questions. There's Kenneth scoping that model.
Oh, can never start too early.
Well, I had to bring them, so yeah. So anyway, well, thanks for letting me share something I care about a lot. I didn't know if you guys go till like 45 or 40.
Are there any questions for Dr. Mariela?
Yeah, Katie, that was fabulous. I wonder if you have ever seen or thought about integrating ultrasonography with the virtual reality, since it's something that you can actually see right through the layers of tissue in a dynamic way. Is that something?
Absolutely, absolutely, and especially because ultrasonography is not something where you can take a still image and gain much data from. So you really need that live, like interactive experience. And so right now we don't have haptics on any of this technology, but could you see a time where you can put your hand on something and have a little bit of haptic feedback, based on how much pressure you're putting on there? We'd be teaching our FNAs in a really different way and something like that. Right now, it would be very easy to add in just the ultrasound images, so you can make sure that you have the full file, not just like a few select snapshots, and allow somebody to kind of go back and forth, and maybe you have that thyroid nodule and it's embedded into our thyroid model, and you can gain that experience. And so I don't think anything's going to take away from doing that for real when it really matters. That's where you're going to learn the best. But to be prepared, to know how to hold your hands, to know which angle to put the probe, to be able to pick different probes maybe, and be able to see different images. I think that's all very much within shooting distance of where we are right now. Yeah. I feel like me, I don't do a lot of ultrasounds. I'm like, is this the long one, right? Or is it like the short little one?
You never know.
I don't know.
Lisa knows.
Yeah. But she's like, oh my God.
I have a good question. It's kind of an ancillary question. I thought your talk was great. Where, right now, given all the things that you've learned new about anatomic variants, etc., where is the living document or living file that we create? Because we still just go back to Netter. We still, because we're just so attached to it. Maybe it's a generation too.
Mm-hmm.
But is there like a, more dominant Atlas platform where we say, as we learn all this stuff, we're going to record it so that we don't have to just keep kind of going down a rabbit hole for our own specialty kind of deal?
Absolutely. So all those publications were for two reasons. Number one, in academic medicine, you pay our teams for publications in many ways, and you show your productivity through those publications. So that was important that we spent a lot of time on all of this to be able to have something to show for it in terms of publications, but also so that we could compile all that knowledge and be able to put it somewhere. And so in those publications, you can see our review of all of this anatomy, but honestly, it's pretty dense to read. And so, like, reading about anatomy can be kind of exciting, but it also can be really dry. And if you're tired and at night you're reading about it, like, it's hard to keep it all straight. So ideally, that will all be in this platform, this digital online platform, where you can go in and if you want to read about it, you can pull all that up. If you want to just interact with it, you can interact with it. If you want to test yourself, depending on what level you're learning at, you can turn that on. Some of those QR codes brought you to a screen where you can turn on the arteries, turn off the arteries, turn on different things, and we'll be able to turn on the labels, turn those off. That's not so new, but being able to add it. So my vision is that this would allow us to put all that knowledge in one space, and then you can choose how you want to interact with it. Like maybe you want to learn how to do ultrasound or understand, what are you looking for when you look at a criteria for what's suspicious nodule now, so that it can all be right there. But yeah, the anatomic literature is really hard to parse through, and it's hard to, unless you're comparing it across studies, to understand, what really is the most dominant variation, and like, do I really trust this one, or maybe this looks at like a really odd angle at it, like they sliced through the tongue and told us how big it was at each level, but that's not really what you need to know. So that's what I'm hoping, is that you can go to this, because same thing, I would have like all these atlases strewn about and carrying these heavy books around, and that's just not really reasonable anymore.
Thank you for your talk, Katie. Is there a potential to translate this into virtual surgery?
Mm-hmm.
Because I think for myself, when I learned anatomy, I had to actually, try to draw things out and, do something active.
Yeah.
And so, with all the information that you've gathered, would you be able to perform, like a cut through the tongue,
Yeah.
and kind of see, what shows up there?
That's definitely the goal. So one thing I think is that I learned a ton from doing this, but you won't learn as much as I did doing it, because I had to like put it together. But that's not good, right? Like I just made something that's the same as everything else. So what I'd like it to be is, I don't know, maybe you have like a puzzle of like all these parts and you have to put them together. Maybe that forces you to actually like look at it and think about it and put it together. I had a mentor. He was a general surgeon. He talked a lot about these are high fidelity models. They're really complex. They require a lot of technology, but he would take felt and then he would cut out the structures in felt and have his residents put the structures in the abdomen together using felt. And something as low fidelity as that, you can just put it in an envelope, send it home to practice at home. Can really help you understand it. So I think you have to do something with it. So wherever we get to, I want it to be so that you can have to build something or touch something or turn it around and be frustrated for a little bit before you figure it out. So from a surgery standpoint, that's definitely where we want to go. So that's that digital twinning and creating those operating rooms. I think we're close to being able to say, I do this step and I see this. I do this step and I see this. I do this step. So you can show the different ways. I don't know how close we are. I think it's more years out to say, I'm going to give you the cautery, you can cut wherever you want, and I'm going to show you whatever you did. Because all of these objects are hollow, and so to be able to make it so that when you cut across them, they have that 3D, this little triangle mesh like all the way around, is a lot harder to make them all solid. The amount of data you need is like quite a lot. So if I just let you cut anywhere in that model, you would see a lot of fragmented triangles and you'd see hollow spaces, which is not what you're going for from a surgery. So I think being able to house enough data to have solid 3D objects is seems harder. But I'm not an engineer. I want to get there though. That's why it's like a long-term career path.
Would you talk a little bit about the amazing infrastructure that you have with Jay and the lab, and where is that? How far is that in terms of the co-location with the OR or clinic or your office? Yeah.
I mean, we're so lucky and it's so amazing.
Yeah.
I think Jay Morris was a professional chef before he went into medicine, and so I think he's got that he just makes things happen. I don't know. So and we're really fortunate. So where our resident treatment room is less than one hallway away from this lab, and the lab takes up more than a full floor in our hospital building on the 6th floor, and so it's huge real estate. And then where that's on the 6th floor and that OR is on the 2nd floor. So it's all right there. So when I need, I get them to print me a model that I need for the OR. We can sterilize it. I bring it in the afternoon. Like when I'm taking out a tumor that I'm never going to be able to see all the edges to, I'll have that model in the operating room and I'll be like feeling back up behind the tear ribbons or something. And I look at the model, feeling the patient, and then you can kind of see, oh, this little, bone nubbin, it looks like it's right here. And so that's where I am with this tumor. And Jay, or one of the neuroradiologists, segments the tumor. It's not a random tech somewhere. It is one of the the MD neuroradiologists that we're working with. And then I look at it with, yeah, that's what I think. I agree with that. I approve. And that's the model that we have. So we're really close. And, if I ask them really last minute, we can run up at like 10 a.m. when it comes hot off the printer and grab it. So that's really nice. It also helps us. I mean, we can do a lot of our virtual surgical planning remotely now, which is nice. So, like, I can be, my clinic office space is a couple blocks away from them. The OR state, we're in 2 different buildings, but so we can do the virtual surgical plan together. But you can also go sit up there and do it. Yeah.
One question.
Okay, that was wonderful. And I had the pleasure of visiting Mayo not too long ago,
Long ago.
a few months ago, and it's remarkable what an impact Katie's had on the department. She's involved in research, education. You're the chair of research, and it's very palpable how much of an impact you've had on the department. So, and when I left, they gave me, Jay Morris and Katie put together a 3D model of a skull as a gift. We don't have something as elaborate, but we do have a gift. Thank you very much.
Well, I understand. I think you had it.
Yeah, just, excellent talk, really interesting. It seems to me there's 2 sort of rate-limiting steps or labor-intensive steps. First is the resolution of the imaging, because I noticed it like superior laryngeal nerve artery and all this stuff. I mean, segmenting that must be really challenging. And then the time-intensive aspect of doing all that, which you mentioned. My question is, do you think there's a role for machine learning or something in helping accelerate this? Because particularly, if you're looking at like orbital anatomy or something like that, which is much finer and really difficult to do segmentation on. Do you think there's, yeah, I see that there.
Yeah, I do. So, I mean, our radiation oncologists are probably leading the field in using, AI algorithms, machine learning algorithms to segment anatomy because they spend so much time segmenting that anatomy. And if they do it wrong, it's really high stakes. So one of my colleagues, David Routman, who I spent a ton of time, doing a lot of my research with, would share with me they had all these companies come in and compete, basically, and try and show who's better at auto-segmenting all these structures. And it's good. But if we want to know where the nerves are, if we want to be able to, like, vaguely understand the lymphatics or something else that we don't have the resolution, even on, like, 9 Tesla scans, like, we can maybe start seeing nerves a little bit more, but, like, not the little ones. And so what that was our medical artist getting information from us, from our literature reviews, from the dissections, and then she puts these little points, along the path and says, is this right, let's move it here or there. And what's amazing is sometimes you're like, that's weird. I don't know why it's making that curve there. I think that's wrong. And I'll like argue, no, that's not right. And then you put in the other anatomy, like of the vessels, and all of a sudden you're like, oh, that's why that is, that's why it's like that. So it is very labor intensive right now. I'm sure that as we do more of this, we can create, algorithms that understand those relationships and be able to build. I think we're pretty far away from that, though. I think, right now they're trying to be able to, with high fidelity, be able to segment things that are easy, like bone, things that are a lot harder, like muscle and mucosa and things like that, so that we would be able to create radiation plans. And that's this is all interdisciplinary, right? Like, whatever they accomplish, as long as we're aware of it, we can bring back into, these types of models. And so I think it's good to be talking to each other, because it doesn't do us any good if everyone, like, in 3 different rooms and it's the same thing. We could make something even better.
Because the holy grail would be to do patient-specific,
Oh, yeah.
imaging, and
for
at
sure.
some point in the future, maybe that would be possible.
And a lot of it, at least our models that we build, but a lot of them are bone, maybe a little bit of vasculature, because vessels are fairly easy to segment. They're not so easy when they get smaller, but they're okay. It's harder on the mouse sometimes because you have so much dental artifact, but we can do a pretty good job and at least create a model that's like semi-relevant to the patient. And so we have that, but to be able to create like really complex, like I forget the name of it, but there's that cadaveric study where they basically sliced up the human body in like 1 million planes, and then you can scroll through it. To have something like that per patient would be really cool.
Yeah, I mean, for the residents, if you're interested, the anatomy department here, there's a, I'm just trying to look up his name during your talk, but there's a famous anatomist who was at Stanford and did these magnificent 3D dissections. And you actually can use a 3D, this is from like the 60s or 50s, and you put on these 3D glasses and you watch these images. We used to teach it in our facial plastics course. Those slides are available here, which are kind of cool to look at.
Wow.
I mean,
That's awesome.
This is a different level right here. So.
Well, in our facial muscles, hopefully, we've got some facial plastics enthusiasts that are coming up to work with me next. So the face is coming. Yeah.
Really inspiring, Katie. Thank you very much. Yeah.